I would like to invite our next speaker, Dr. David Nicolás from Spain. Dr. Nicolás is a medical coordinator of the Hospital in the Home program at Barcelona. He's an associate professor and director of a training program specific to hospital in the home at the University of Barcelona. He has been practicing OPAT for over 10 years, including as a lead of an OPAT program at Hospital Clinic in Barcelona. He will be sharing us his perspective as practiced in Spain.
First of all, on behalf of the Spanish Society of Hospital at Home, let me thank the organization for giving us the opportunity to be here today to share our experience. It's always a pleasure to speak with other colleagues around the world doing similar things as you do. So I'm here today to talk about the Spanish model of hospital at home. We call it hospital at home, not hospital in the home. I hope this is the biggest difference we may have. And it's safe to say that here in Spain, we stand on the shoulders of giants because we've been, here in Spain, the model of hospital at home is quite vintage now. The first experiences of hospital at home were in the 80s, first in Madrid, in the Hospital Gregorio Marañón and the Hospital Clínico San Carlos. In my hospital is this one down here. They started with hospital at home in the late 80s, 1989. And this is not a casualty. This is because some of you may remember that in 80s and 90s, we suffered another pandemic, the AIDS pandemic. And I think this graphic, probably, this is from Spain, but probably in Australia or in other parts of the world, you have similar graphics. In the 80s, 90s, our hospitals were crowded with AIDS patients having complications from the AIDS, Kaposi sarcomas, PCPs, toxoplasmosis. So there was a need for a solution for these patients. And one of these opportunistic infections was the retinitis by cytomegalovirus. And the treatment of retinitis by cytomegalovirus was ganciclovir. Ganciclovir is a long treatment, IV treatment, and some people, some doctors thought that, well, why can't we provide this treatment by a central line at home? And I have to say that today, 2024, giving ganciclovir by a line in home is not the easiest treatment we provide. So I think that in 1996, they started big. They started with the most difficult part. So after this, it's just logic to think, well, if we are giving ganciclovir, why can't we give, I don't know, ceftriaxone or furosemide? So this was the start of a long trip that give us or get us to what is today hospital at home in Spain. This is that data from the Spanish Society. This is the distribution of the different hospital at home units in all Spain. Spanish system is a public universal health system, so no one has to pay for it. But we have a very decentralized system. So every region has a local government, and this local government can manage their budget in certain ways. So you can see that the development of the hospital at home model is quite heterogeneous in all our country. For example, in Catalonia, where my hospital is a very developed region. So we have nearly each hospital has a hospital at home units, but there are other communities that, other regions that don't have this spread of the model. We have some local societies also for hospital at home here in Catalonia, in País Vasco, in Valencia, that group the hospital at home. Two invitations for you, for your audience. This is our journal, the journal from the Hospital at Home Society in Spain. Here we publish works on hospital at home specific. I think it's one of the only journals in the world publishing only hospital at home topics. So you are really invited to read it and, of course, to contribute. And another invitation to our annual congress. We every 2 years, no, it's not an annual congress, every 2 years we meet all the hospital at home units in Spain. We meet in our national congress. This year will be in May in Bilbao, and you are mostly welcome to join us. But this, don't get me wrong, this has been a long trip. The model of hospital at home in Spain is quite heterogeneous, has been quite heterogeneous. But in the last years, we are working towards a standard definition of the model and homogenization of the care in hospital at home. This is one of the main steps that we have taken in the last years. This is a document generated here in Catalonia together with the government and the Catalan Society for Hospital at Home, in which we define what is hospital at home, and this is not small. Hospital at home is a substitution of brick and mortar hospital admission. It has to provide the same quality standards as conventional hospitalization. It has to provide a full coverage, 24/7 coverage, and hospital at home units are responsible for all the necessary care for our patients. And also, we have to be flexible enough to adapt to any clinical changes in our patients. And of course, we need to provide service for all medical and surgical specialties. And listen, it's so important to know what is hospital at home, but it is even more important to know what is not hospital at home. And hospital at home is not follow-up of chronic condition. This here in Spain is primary care. It's not palliative care, at least not alone. It's not follow-up by only one professional role. It's not a service of nurses going to houses. It's not emergent home care because this is another service. And it's not alone virtual only care programs. And this is quite important for us. In-person visits is a requirement for hospital at home here in Spain. And here I know I'm walking on thin ice here, but I think it's important, I think that we have evolved here in Spain from a very OPAT focused model to a more integrated hospital at home model. I like this work from Professor Montalto. I think that OPAT, it's a model for antibiotic delivery at home with a supervision from an infectious disease doctor, and it's mostly early discharge patients that are at the hospital, as our colleague has just explained. Hospital at home model tries to replicate inpatient care, fully replicate inpatient care, has their own staff supervision, provides full 24/7 all-day care. We treat multiple diseases, not only infections, but we can treat medical, surgical complications, and we can provide also admission avoidance, as I will tell you. I will be happy to discuss this afterwards. So, a big picture in Spain, we have these 5 models of care. The most frequent and big one is the acute hospital at home for adults, but we also have pediatric hospital at home, subacute hospital at home, very focused on rehabilitation, physical therapy. We have psychiatry, mental health for adults and kids at home. And then we have some specific hospital at homes, very specialized, like bone marrow transplantation at home that is driven by hematologists. What does our unit, what do our units look like here in Spain? Well, this is also big picture data from the Spanish Society. You can see that 43% of our units have more than 20 years operating, so they are quite experienced. And you can see also that most of our units have between 26 and 100 beds capacity a day. So they are like medium, big hospital at homes. And then who is working in our hospital at homes? We have, of course, we have doctors. Most of us are internal medicine doctors or infectious disease doctors. Here in Spain, we don't have a differentiated specialty for infectious diseases, just internal medicine doctors that we specialize in infectious disease. We have some units run by family doctors or GPs, some of them run by geriatricians, and then we have some mix of pneumologists, some surgeons, some pathologists, some psychiatrists working in hospital. We have nurses. Nurses are the cornerstone of our units, are the most important piece of these units. They need to be experienced, they need to be trained. We have nurse aides and we have advanced practice nurses. We don't have paramedics in Spain. This role, it doesn't exist. And then we have some allied professionals such as physical therapists, nutritionists, social worker, or administrative staff that are really, really necessary to coordinate all this activity. And here you can see three of my colleagues. You see Ainhoa, the doctor, you see Eva, one of our nurses, and you see Ainhoa, one of our physical therapists. So going to from the big picture to the small picture, you see here the evolution of my hospital at home. I think it's quite representative of how the model in Spain has evolved. We have come from a model of an OPAT model hospital at home, very focused on infectious disease. But in the last 6 years, we've been growing towards the actual model. You can see that we've been increasing. 2020 with COVID-19 was a really game changer for us, because I think that put everyone in the same mindset that that the patient can be at home at certain times, and this is the best place to be for these patients. Nowadays, we have a capacity for 72 patients, and also we have 11 beds for mental health patients, both adults and adolescents. This is the evolution of our activity. You can see that in 2020 we had a peak of activity because of COVID-19. We treated patients with COVID, we treated patients without COVID. Nowadays we are someplace around the 2,500 discharges a year from hospital at home in my hospital, in hospital clinic. And when we look where do these patients come from, we see that from these 2,400 patients, 40% of them are from this model that we used to call early discharge, and I'm waiting for someone to come with a better term because I don't like this one, because our patients that come from the hospital at home ward, from the hospital wards, and go to end the admission in hospital at home. And 60% of our activity is admission avoidance. I don't like this term either, but it's to refer those patients that don't put a foot on the hospital ward. This is interesting because it used to be the other way around. Like 10, 15 years ago, we used to have more patients coming from the hospital, but we have changed this model to completely avoid hospital admission. If we look at early discharge, we see that most of our patients come from surgical wards, and 46% come from medical wards. And from these patients coming from surgical wards, you can see that most of them are what we call early home transfer. Early home transfer mean patients coming from a non-complicated surgery that complete the admission, the normal admission, at home with hospital at home. Of course, we have a big pool of patients with complications of surgery, most of all infections. And we have published this experience recently in Annals of Surgery, describing 6 pathways for early home transfer. We have an early home transfer pathway for bariatric surgery. They go home 24 hours after surgery. We have an early transfer for a kidney transplant. They go home at day 3 after surgery and complete the normal 7 to 10 days of post-surgery at home. We have the same for lung or thoracic surgery, cystectomies, appendicectomies, and we have just started with abdominal wall. And I think this is one future pathway for a hospital at home, non-complicated surgery. It's something that we have to explore further. Regarding admission avoidance, we have 2 main pathways. One is from the emergency room. The patient arrives to the emergency room, is diagnosed with, I don't know, heart failure, pneumonia. So we evaluate this patient at the ER, and we take the patient home with us. But we also have a very interesting pathway with GPs, with general practitioners and outpatient clinic, where the patient is identified as a good candidate in their home, and we go to the home to evaluate this patient. So this patient don't move from their home we go there and admit the patient directly in their place. Most of our patients come from the ER, but well, there's a 17% of them that are directly admitted at their home. And I think this pathway of admitting patients directly in their home is one that has a lot of future. What can we do at home? We can provide tests, blood tests, cultures, clinical ultrasound, AKG. We provide nearly every treatment by the line. Normally, in my unit, we don't use elastomeric infusors. We use electronic pumps, but there are many units using elastomeric infusors. We provide blood transfusions, iron therapy. We provide oxygen, we provide nebulized treatments. And one thing that is interesting that 2 years ago, we started placing midlines and power lines at home by our nurses, trained nurses that can place the line at home. So just to end this and to provide some insights of what I think the future of hospital at home in Spain will be, or what are the main issues that we need to address. I think that we have to look on value, but I don't really like this classical value model because it has these cost things that I'm really bored about. I think that we've been like the last 10 or 15 years trying to prove that our model is cost effective, and it's not. I don't think it's a target anymore, because it's very difficult. It's very difficult to compare costs from conventional hospitalization and hospital at home. Every study is not comparable to the next study done. So I think we need to forget a little bit about this classic model of value. We need to put value for the patient in the middle, and we need to look for clinical quality and safety. We need to explore telemedicine options, because here in Spain we are just starting with this. So we have a long pathway among us. We need to explore the use of artificial intelligence in our units, mostly for patient selection, which patients can be admitted in hospital at home, but also to stratify our patients into different categories. And also we have to explore the pathways that avoid admission of the patient, because this really brings value to our patient. We need to explore the experience of our patient, the reported outcomes, the reported experience, but not only from our patient, but also from caregivers. We need to really explore well what is the burden that we are giving the caregivers. But for this, it's really important to generate specific hospital at home PREMs, because now we are using PREMs validated for conventional hospitalization, and this is not optimal. We need to include PROMs hospital at home in PROMs evaluation for different conditions. And this is one advice: if you are trying to create something new in your hospital at home units, why don't you include patients in these decisions? They will tell you some things that you have never thought about. And finally, we need to have results. We need to benchmark with other units. We need to define and share KPIs. What are we going to evaluate in our units? We need to publish our results. It's incredible that we've been working in hospital at home for the past 40 years, and we haven't really created evidence for hospital at home. There's a lot of evidence lacking. We need to explore intermediate customer experience. We need to know what the other doctors in our hospital think about, what the community think about our hospital at home. And of course, we need to advance in specific teaching, specific training for hospital at home. Here in Spain, we have our master degree, but any other ways to train professionals into hospital at home has to be developed. So this is all I wanted to tell you right now, but I would be very glad to discuss afterwards. Thank you very much again to the organization, and this is our beautiful team here in Barcelona waiting for you anytime you want to come to visit us. Thank you very much.
Yeah, thank you. Very interesting talk. So I would like to remind the audience again, so you can still put your questions under the Q&A tab, and we will have a Q&A session at the end. So